Thank you all for joining us for this month's Science Cafe on disaster preparedness. For those of you who are not familiar with the CTSC, I just wanted to provide a brief overview. So the goal of the CTSC of Northern Ohio is to improve the health of those that are living in this area by providing resources and services to our hospital and university partners, clinical and translational researchers and scientists, as well as community members. The CTSC is currently doing this by focusing on these 5 key areas and initiatives. So these are resources and services, workforce development, community engagement, health informatics, and clinical and translational funding opportunities. I wanted to introduce our presenter for today. So Dr. Macias is the Division Chief of Pediatric Emergency Medicine and the Chief Quality Officer for University Hospitals, Rainbow Babies and Children's System of Care. He also is an associate professor of pediatrics at Case Western Reserve University. As an improvement scientist, he's driven multiple initiatives that target improvement in child health outcomes locally, nationally, and internationally that include large quality improvement collaboratives. These efforts have helped to solidify both strategy and implementation of infrastructure improvements within the national healthcare system for preparedness in the care for children, reducing mortality as well as the burden of care. So I will turn it over to you.
Great. Thank you. It's certainly a pleasure to be able to share some of our concepts around pediatric readiness and strategies that are really enhancing disaster readiness for healthcare infrastructures across the country and across the globe. By way of, seems like I'm having a little challenge with advancing slides. Are you seeing the disaster readiness slides?
Yes, just that
title
introduction
slide.
See, if you try to click your screen, does that advance it?
You're also muted.
There we go. Now can you hear me?
Yes.
Perfect. Okay. So by way of disclosures, we are funded through a number of resources that includes the Health Resources and Services Administration, as well as the Administration for Strategic Preparedness and Response. The sum total of commitments for pediatric disaster research and readiness exceeds $100 million over a 5-year period by ASPR, HRSA, HHS, and the U.S. federal government. None of the content presented here are to be construed as an endorsement or the official views of ASPR, HRSA, HHS, or the federal government. Pediatric everyday readiness and disaster readiness really sits on the concept of the capacity and capability of healthcare systems to care for children. When we look back at the burning platform that created so much of the infrastructure that exists today that didn't exist 10 years ago for pediatric disaster readiness, disaster research, there were a number of healthcare needs identified. The first of those is that children account for 20%, really 22% of the US population, and have very unique healthcare needs. About 35 million children each year seek emergency care, but the vast majority of them do not present to children's hospitals. Over 90% present to general or community emergency departments. There are challenges in access to pediatric emergency care and to subsequent inpatient care, recognizing that over a decade, about 20% of all pediatric beds, that's about 1,000 beds, were lost, shut down for financial or other reasons. There's been a historical focus on adults within our healthcare infrastructure, and so disparities continue to exist for pediatrics as compared to the adult population. Recent disasters have really exposed and exacerbated those gaps, and we saw a lot of this in the respiratory surge of 2022 and 2023 when all of our gloving, gowning, hand washing, masking, and strategies around the pandemic for COVID-19 resulted in children who were 3 years or younger that had never really experienced viral patterns, thus leading to this surge. The concept behind disaster readiness really rests upon that pediatric readiness. When we look at emergency care systems, we recognize that healthcare systems have to be accessible and capable of meeting the needs of children, especially recognizing that over 90% of them are going to present to community-based hospitals. In a survey of over 4,000 hospital EDs, last conducted in 2021, with 7 domains of quality, what we have recognized is that first quartile scores are associated with a 76% reduction in mortality, with a 60% reduction in mortality for injured children. So whether it's medical or injured trauma, we see these reductions in pediatric readiness hospitals. The challenges is that in those prior surveys, we've demonstrated that greater than 50% of hospitals do not have disaster plans that include children. That creates a great barrier for accessing care that is going to be of high quality for families and children. What we do know that the drivers of pediatric readiness is that rests with pediatric emergency care coordinators in emergency departments, and we see double-digit increases in readiness for kids, and we're seeing that happen in pre-hospital systems, that's EMS systems, over 17,000 of them. We have an opportunity to drive enhanced quality improvement within hospitals, especially community-based hospitals, with participation in pediatric recognition programs, some of those hosted by a federal arm of Maternal Child Health Bureau, the Emergency Medical Services for Children arm. And we recognize that if we had universal pediatric readiness across all emergency departments, that we could save at least 2,100 lives annually for a cost of less than $12 per child. So everyday readiness is the foundation of pediatric disaster readiness. How can a healthcare system, how can a hospital emergency department that can't care for children on a random Tuesday be prepared to care for children in a mass casualty incident or in a global health threat like a pandemic? But the federal investments in improving everyday and disaster readiness have its roots back in 1984. The Emergency Medical Services for Children program grew out of a recognition by the federal government that changes made in the late 60s and early 70s that grew the healthcare system emergency readiness for adults, primarily targeting trauma and cardiac care, which included strokes and MIs, really led to improved outcomes for adults. But it would be 20 years before that recognition that children needed that same level of investment grew. Unfortunately, that level of investment didn't amount to what it was on the adult side. In fact, that first EMSC program, the only program authorized to oversee improvements in the emergency care system for children, started with an only $2.5 million budget. In the 1980s, the first EMSC funded grants were awarded to states. That grew to a much larger network, now involving 57 state partnerships, which began in 1997. Replacing individual state grants, so 57 state partnerships, including jurisdictions. That recognition, that structure alone couldn't get to what we needed to get to improve outcomes for children, meant growing an evidence base. And that began with the Pediatric Emergency Care Applied Research Network, or PECARN, that was created in the early 2002 to be exact, that now through various funding streams has over $100 million in research funding. That led to efforts to improve the Readiness Project, and that National Pediatric Readiness Project now has had 4 iterations of surveys of healthcare systems to understand how ready across 7 domains of quality healthcare institutions are to manage children. Over the course of time, however, we recognize that the intensity of that need really culminated with the intensity during disasters. So that led to a recognition of a need for creating networks that would enhance disaster readiness specifically for children. The then Assistant Secretary for Preparedness and Response launched 2 pediatric disaster centers of excellence, one of them located here in Northeast Ohio, and that's at Rainbow. Since that time, ASPR added a 3rd PDCOE, and we'll talk a little bit more of what that looks like. But the biggest investment really came when the Pediatric Pandemic Network, and although entitled network because it emanated from a pandemic justification, actually covers disaster readiness and everyday readiness. So those 3 pediatric disaster care centers of excellence under the Administration for Strategic Preparedness and Response were the original 2, that's RAPIM listed in the 2 columns on the right, and the Region 5 for Kids based here at Rainbow, and the 3rd that was introduced was awarded out of Houston, or to Houston, out of 7 states. So now that put the 7 states of the Gulf 7 plus RAPIM, 6 additional states, and 6 in the Midwest through Region 5 for Kids into a new administrative structure that would support regional investments in disaster readiness for children. Couple that with the original EMSC investment, which supported the EMSC Improvement and Innovation Center through 4 pillars of work: pre-hospital care, trauma care, and disaster preparedness, through this network of 57 state partnerships, including the jurisdictions, now had cross-cutting elements in advocacy, research, knowledge management, QI collaboratives, analytics, and value-based care to support a QI structure for that work. But we needed to close the gap on a number of issues that were being seen with children that were happening concurrently and exacerbating those disaster and everyday readiness issues. And that included this epidemic that we're seeing in mental and behavioral health for children. Through the pandemic, we saw increased volumes, increased boarding, not because of the pandemic, but trends that were already occurring, with a 35% increase in mental and behavioral health visits in emergency departments that was happening over a 10-year period. In fact, adolescent suicide in Ohio is the leading cause of death in adolescents. There was a further gap in community engagement that we recognized during the pandemic, while staffing in the workforce led to the great attrition of over 18% of the workforce being lost in healthcare. There were gaps in coordinated national pediatric and disaster readiness strategies, and gaps in the surge capacity and the ability to care for kids over state lines. So Congress then supported the Pediatric Pandemic Network with a commitment initially of about $10 million a year for 5 years that subsequently grew to the addition of 5 additional hubs, bringing that level of funding up to $18 million per year. And that subsequently increased in 2023 with a new appropriation to expand pediatric disaster science research to now a $25 million a year investment in that network alone. The pandemic network goals included expanding children's hospital partnerships with local, state, and national ED preparedness systems, collaborating with communities, improving pediatric readiness, increasing the capability of telehealth systems, accelerating the development of and dissemination of research-informed pediatric care while increasing the evidence base, therefore coordinating research-informed responses to disasters and health threats that would impact children. This map that only had a couple spots on it 10 years ago now looks incredibly comprehensive, with a network of children's hospitals engaged in pediatric everyday readiness as well as disaster readiness. And the legend there reflects the hospital's networks as well as the map itself identifying the hospitals that are hub sites of the pandemic network, as well as hub sites for the EMSC program, the EIC, as well as the Administration for Strategic Preparedness and Response Centers of Excellence. The PPN itself, through 23 domains of work, functions with service corps, everyday domains, and disaster domains. Those disaster domains include efforts at improving capacity and capability. That's surge toolkits, pediatric vulnerability assessments. CBRN, that is chemical, biological, nuclear, and radiologic threats. So partnerships with national organizations and tabletop exercises conducted across the country and actually now internationally for facilitation of strategies and identification of gaps in healthcare infrastructures. Deployable assets, these are DMAT teams, as well as medical operations corps that can better track assets for disaster readiness across state lines and within states. Drills and exercises, testing pediatric disaster plans and surges, reunification efforts, improving local and regional family reunification planning, and supply chain shortage mitigation. We saw a lot of that supply chain shortage during the pandemic with masks and other PPE initiatives. The PPN itself has a number of key project examples, a national data portal that allows us not only to share data across hub sites and their partners, but a companion education repository called Resource Central that utilizes advanced AI modalities to hone in directly on pediatric relevant resources. And other initiatives, pediatric disaster science support. You'll hear much more of this in detail in the slides to come. Resource dissemination, data collection, conducting surveys, focus groups, Delphi events, talk a little bit more about that. Community engagement, bringing in schools and other community entities into pediatric readiness and disaster readiness. Education, trainings and course developments for pediatric disaster education, as well as partnerships, really expanding our partnerships with professional societies and aligning priorities nationally to get to improvement strategies that will really drive care. PPN has been critical in our responses, whether it is the triple-demic, the Maui wildfires, staff shortages, reduced pediatric beds, weather threats, over 199 disasters that affect children each year when considering just the natural disasters alone. So these are important questions and important gaps that need to be addressed. But critically important in understanding disaster management is understanding the opportunity for data-driven disaster management. As the Chief Quality Officer for Pediatric System of Care, I lean heavily on the principles of improvement science, with analytics being a core tenet of that work. A Donovan framework really defines how we get to better outcomes. Structures that need to be in place to drive processes with high reliability to those processes that ultimately can lead to better outcomes. All too often, we as healthcare systems jump right into processes without identifying the structures that are going to be able to provide the resiliency and the reliability during disaster responses. So using data becomes a critical part of that. The maturity of analytics in healthcare systems takes us from simple data reporting, such data about a patient, for example, to analytics, really understanding patterns in data, to predictive analytics, for example, modeling what we might expect to see in a surge. So complex models in disaster science have heavily leaned into artificial intelligence and augmented intelligence through machine learning to really shorten the time to the derivation of a prediction model to getting that we can get from big data so that we can have more and more of those prediction models. A lot of that literature that's emerging in disaster readiness and disaster science have defined flood hazards with spatial data, flood risk assessments defining risk to neighborhoods, ventilator allocation models to define where the best distribution during global health threats could exist. The list really goes on, but the opportunities for us to engage in this kind of research is wide open. Lots of opportunities, and machine learning and AI can really help drive a lot of that health services research. But analytics alone is really insufficient to improve the outcomes. Access to data is insufficient without a system savvy to see the patterns in the data, either through analytics or through quality improvement structures. And those QI processes and structures need to be in place to turn insights into improvement. So this is where improvement science really allows us to drive change, to study that change, to adapt, to adopt, or to abandon. After all improvement is change, but not all change is improvement. And data and analytics should really drive those decisions, especially when we're talking about policy changes. Data-driven approaches to disaster really touch all phases of the disaster cycle, whether it's preparedness, whether it's response, whether it's recovery, or whether it's mitigation with future prevention efforts. We can infuse sophisticated models, understanding that there are opportunities, 3 large challenges that we can overcome, especially with relevant research. Effectively capturing status information from diverse data sources is the first. The second is effectively capturing the user's interest in delivering relevant and digestible analytics. And the third is leveraging community information from the disaster recovery phase. Data to insights becomes critical to enact improvement strategies to build resiliency, such as better systems to mitigate the impact of floods across large geographies, or capacity management systems in medical surges. There are advances that we are continuing to see in data-driven approaches to disasters. Big data, that's high volume, high velocity, highly varied data, enables observation of post-disaster recovery with great granularity that can be used to calibrate really dynamic models to capture characteristics of the disaster resilience process to drive refined processes and policies. These models can use multiple streams of data, not just limited to our generated data, but inputting social data, for example, to define community resilience. Such outputs are illustrated in the map there of Puerto Rico, showing housing damage rates in red, coupled with social and physical systems pulling data from mobile phones post-Hurricane Maria. Very sophisticated models that are using all the data resources to understand impacts to our community. The COVID-19 pandemic highlighted a need for better understanding countries' vulnerabilities, specifically, and their capabilities or their resilience to not only manage pandemics, but manage all disasters, climate change, and other systemic shocks. So that's the illustration of the vulnerability modeling that you see on the right for a country's vulnerability. So all of this kind of health services research really has provided us some opportunities to bridge the initial recognition of gaps that was described by the National Commission on Children in Disasters, in which setting a clear and specific research agenda for the needs of children during disasters was outlined as early as 2010, post-Hurricane Katrina. Pediatric disaster science, research, and innovation really comes from our ability for the existing networks, where our opportunities within this region are really bridging gaps in pediatric disaster science. What this particular illustration demonstrates is the framework for understanding this relationship between operations, with management there in the right part of the Venn diagram, improvement science, which really drives the everyday quality improvement piece illustrated in the middle of that management, and applying this intersect with research and policy, whether that policy is local or national. So let me give you an example of how we might apply all of that. If we applied this to telehealth and disaster science during the pandemic, we rapidly pivoted as a national and local healthcare systems to take on a technology we had never known before. And that management or operations strategy was critical to getting healthcare to patients and families that desperately needed it. But that required policy changes for reimbursement, policy changes for access, and for rapidly changing credentialing. But research is necessary to understand how those policy changes, how those funding mechanisms, and how the operations of all of that work would influence the next generation of telehealth and what it could look like in the future. So that kind of research is currently gapped, especially when it relates to pediatric disaster science. We, through the Pediatric Pandemic Network, undertook a modified Delphi process to understand exactly what is the science that exists in pediatric disaster readiness. We did a scoping review and found only 728 pediatric disaster peer-reviewed articles. They're illustrated in the pie chart there with the categories of the themes within those 728 pediatric articles. The interesting thing about that is if you look at the timeline of the number of publications each year, it was really Hurricane Katrina that spurred a large increase in the body of evidence that was being published around disaster science for pediatrics specifically. And that increase seems to happen after very large disasters. Its biggest increase, of course, with COVID-19. So when we conducted our modified Delphi process, we had the pre-Delphi followed by round 1, 2, and 3 of survey, meeting, and subsequent meeting to rediscuss topics around 5 thematic areas: response, recovery, mitigation and prevention, preparedness, and education, which each of those defined to the participants that were generating the next generation of the research agenda. So that research agenda or research priorities was intended to influence back some of the strategies undertaken in partnerships with the NIH, with the CDC, as well as with federal entities that are applying this evidence. And you can see the specific subtopics that are influencing that research priority. And with these research priorities, we were able to cross this over into the priority areas of the pandemic network, as well as the other network assets. And that included focus areas in infectious diseases and disease outbreaks, mental and behavioral health, and all of these are specific to pediatrics, emergency and disaster management, and community engagement, including issues of equity in geographic healthcare and other related equity issues. So we within the networks, and this is where the opportunities for everyone on this webinar can engage with, is really creating opportunities for institutions and for people. We've developed a disaster science curriculum now in its second offering to help bridge a gap for the shortage of researchers in the pediatric disaster science space by increasing the amount and the intensity of training in this new space. We also have launched a Pediatric Pandemic Network Scholars Program that allows mentored career development for multidisciplinary, multi-specialty participants. The Scholars Program includes projects that are developed over a 1 to 2 year period, and the application process exists every 2 years for our PPN scholars. We currently introduced 19 new scholars, and we're delighted to have them in place. That process includes identifying a project, developing mentors in collaboration with those national mentors, monthly meetings, and product and presentation support throughout that process. Additionally, the PPN bridged a gap in pediatric disaster science with career development. We developed a clinical scholars program that is a career development award, awarded 4 of these last year. That's $125,000 per year to cover what is presumed to be half an FTE for anybody selected for that career faculty award program in pediatric everyday readiness or disaster readiness science. In addition, we offer a pilot study program support. These are pilot grants of up to $50,000 per year times 2 years. We've awarded those in 2023 and 2024 with 9 new awardees soon to be announced within the next 2 weeks. Those focus areas for those awards are disaster preparedness, mental health, infectious diseases, and community engagement, aligned with the priorities we've identified as themes, but also aligned with the research priorities in terms of structures from that modified Delphi process. We have a number of PPN-wide research initiatives. For example, we're studying the impact of COVID on mental and behavioral health issues in children now across 14 hub sites, hospital hub sites and their partners. We're implementing interventions that will prepare communities for future disasters. We're partnering with other networks, and part of this outreach today is exactly for that, to understand what new hospital partners and what new researchers could join us within that group. And that research doesn't just stop at health services research. It moves into regulated medical devices and software, offering support for innovation as part of a BARDA network, innovations network, looking at new opportunities, even being able to codify new devices and softwares as countermeasures in multiple types of disasters. We host an annual research and innovation conference. This year happens to be hosted in Cleveland, the second week in August, but shifts from place to place annually. We also have a goal of assimilating research best practices. So it's not just taking that tacit knowledge or creating that tacit knowledge, but moving it into the assimilation in a timely fashion. That's really critical during disasters. We want to ensure the capability of any organization to deliver the highest level of quality and safety for children. So building organizational reliability is a little different, but related to resilience. It's key to evolving high quality and safe care for children every day as a first step for being able to care for them in a disaster or a global health threat. This is especially true for healthcare systems that treat adults primarily. We need to make them ready for those rare events. But the tenets of high reliability organizations are very critically applied to disaster science, and that includes making institutions and their staff members really expert in their management. That's including a deference to expertise, ensuring that we inform decision makers, including local policymakers, and educating the workforce to the needs of children in disasters. This is also includes a reluctance to simplify, growing structures that have the capability to address necessary complexity with robust data and analytics that includes surveillance data specific to children. The third is a sensitivity to awareness with bidirectional knowledge exchange at all levels of workers, such as understanding pediatric nursing workforce shortages, a commitment to resilience, building and empowering teams for functional collaboration, and finally, a preoccupation with failure, embracing the need to address failure or potential failure in disasters. High reliability organizations is not a foreign concept. There are so many institutions. In fact, most hospitals went into hospital incident command system mode, which is a model of HRO performance. So we see that happening. We need to make institutions more reliable. And we do that with national collaboratives within our networks. These are quality improvement collaboratives. These are networks for shared learning. They translate research into practice. They discover new knowledge, and they close quality gaps using known competencies in the Institute for Healthcare Improvement design of quality improvement collaboratives, and those are listed there. We have undertaken national collaboratives with over 100 hospital systems at various phases. Some engaged in disaster networking, bringing related entities together over the themes of pediatric disaster readiness, disaster recovery, and response collaboratives. That's the current collaborative that we're engaged in, and a new launch of a pediatric readiness collaborative. With over 100 hospital systems engaged in these collaboratives, we've been able to demonstrate improved readiness scores, as is illustrated in the upper left there. Ultimately, and in summary, what this illustration reminds us of is that if we are going to get from bench research to clinical studies to improvement, that we can take a route as a national healthcare system that includes poor diffusion, low quality care and outcomes, and focus so much of our burden and dollars into quality improvement, or we can take adequate diffusion from the onset, being attentive to high quality care and outcomes in our design. And our network really helps us to achieve that goal from the onset, really eliminating the waste in that process. There are opportunities here in all of what you've heard to participate in. All you have to do is access any of our resources with these web addresses. You can find us on Facebook, X, LinkedIn, any number of resources. And with that, I will open it up to questions.
All right, great. Well, thank you so much for that presentation. If anyone has any questions or comments, feel free to unmute, or you can put your questions in the chat.
Mackenzie, I can't see the chat, so I will count on you to let me know.
Yes, I just see a comment back from 12/12. So earlier in your presentation, Sherry said these are tremendous networks. So just a comment.
Yeah. Thank you. We are delighted that that federal investment has existed to support the networks. They are expansive and they are ever growing. Our intent by the end of 2026 is to have 80% of all the children's hospitals, which is 188 of them, participating in the pandemic network and leveraging all those partners. We are, even though we have roughly 17 affiliated hub sites, we are now up to over 121 hospitals that in some form or fashion are partners in all of this work. So we're close to hitting that goal.
I see that Shannon has her hand raised.
Yeah, thank you. Dr. Macias, this is Shannon Switkowski. I'm the executive director of the CTSC. And I'm just wondering, of those partner networks, do you know how many CTSAs are involved in these networks as well?
I am not certain what that number looks like today. When we originally had the 10 original hub sites that were under the second set of appropriations, 7 of those 10, so 70%, had CTSA, CTSC affiliates. And those researchers were informed of opportunities. We are seeing crossover in a number of partnerships, especially with our pilot grants, because I think it's a good opportunity where we would like to see more participation is in taking those pilots up to larger grant funds.
And then in rural areas as well, I know that's a big focus of the CTSA program currently. Are these reaching the rural populations?
So I would say there are, by design, rural populations that have been included in the selection of a number of our hubs. So I'm going to point to Salt Lake City, Intermountain Health, and in fact, working with a number of rural Indian Health Services related entities and activities. We have specific projects working with Indian Health Services that are looking at bringing pediatric readiness into many of the tribes, some of it with telehealth and echo programs. Similarly, pointing to some of our work in Louisville and Appalachia, focused areas there with efforts at bridging some of those equity initiatives there. A lot of that exacerbated in recent hurricanes.
Yeah, I was going to say, if there's ever an opportunity, we're working on our rural health kind of strategic plan if there's ever an opportunity, we can collaborate with that. So we'll be in touch. Yeah.
Yeah. Oh, absolutely. I think that opportunity is always there. And I do think because of the way that our small to medium to large funding structures look and what we're trying to push forward, it doesn't necessarily even require that we find additional funding. We just link some of that pilot work to start with.
So I'm not seeing any questions in the chat or any other hands raised. I'm just wondering if there's, people on the call, if they'd be willing to share, are they doing work that's related to this? Are they interested? Just kind of a brief background about, why you're interested in this topic.
I'm curious, and I'm not certain if this is a question for individual audience members or if this is a question that could be answered by CTSC leadership. But as we look at the types of research and think so much of disaster readiness research happens in the health services research space, what does that look like for CTSC? What percentage of your researchers would identify themselves as health services researchers? And are there members or are there participants on the webinar that identify themselves primarily as health services researchers?
That's a really great question. I don't know if Jerry Tennant's on the call. She's our research navigator. Maybe we could look that up in our Spark system. That's our capture for requests in the CTSC. I don't think that that's necessarily a category we're capturing right now. Perhaps it should be. So, off the top of my head, I don't know, but we certainly can dig. And others on the call, if you identify, feel free to jump in.
And I asked that question really sort of launching off the question you asked or the comment you made about earlier about collaborating, because I think this is the area of organizational readiness where we have the greatest opportunity, but we're not limited to that. I think, when we describe these 4 themes here, if there are researchers focused in infectious diseases and disease outbreaks, if there are researchers that are looking specifically at rural community outcomes, or if there are mental and behavioral health elements, this is all part of where themes or types of researchers can interact and hopefully partner in some of those resources that we're able to disseminate, whether it's pilot grants or career awards.
Hi, this is Jerry. Shannon's right. Our membership survey asks about research interests, but it does not ask the type of research that the individuals do, which is a really good thing that we should probably be asking. I think I've had this question come up twice actually in the last month about the type of research. So that is something we would like to know about our membership for sure.
Sounds like a good opportunity.
And then the pilots that you just mentioned, is there somewhere we can visit to see the examples, or could you share some of them?
Yes, you can view the examples if you access the website on the PEDS Pandemic Network. That's the first one there, pedspandemicnetwork.org. And I'm going to see if I can pull up a summary without names, but I can describe some of the themes since we haven't officially announced the new pilot awardees for 2025. Well, unfortunately, my internet access is slow, and I think probably because I'm consuming a lot of bandwidth for the webinar part. But here we go. All right, so evaluating the implementation of a comprehensive checklist of pediatric-specific disaster considerations on a hospital's pediatric disaster preparedness, anticipating, plan, deter, responder resilience system, and SciStart, psychological simple triage and rapid treatment responder pilot for pediatric disasters, developing regional criteria for pediatric interfacility transfers to improve surge preparedness, improving disaster preparedness strategies for neonatal care in one state, considerations for post-disaster biometric uses for family reunifications, family snapshots assessing post-pandemic family experiences, pilot implementation of prediction and response to emergency department increases in crowding and treatment evaluation delays, an innovative pilot youth development program informed by health justice, community resilience, disaster preparedness, and critical consciousness principles, machine learning to improve outcomes amongst emergency department youth at risk for suicide, predicting clinical deterioration among children with out-of-hospital emergencies, setting priorities via rapid engagement of community partners for pediatric research ethics preparedness. So that just gives you a sense of the broad scope of that kind of work. We fund a lot of things.
And to go off of that, Jerry asked in the chat if you could share some of the eligibility criteria for these awards.
Yeah, so 2 years of funding, 50,000 a year max. We are not able to support FTE for the awardee, but we can support FTE for others involved in the research, like a project manager or a research coordinator. Other eligibility criteria is being an affiliate of a hub site. Because we have so many affiliates now, if anybody were interested, we would collaborate to provide you that affiliation so that you could be considered an affiliate, and we would set up a subcontract. The only other eligibility is the institution has to agree to doing this without any indirect costs. And that's for that one award. The career development awards are different. That's a commitment of at least half an FTE with a division or institution supporting whatever the difference between the 125,000 and the half a 0.5 FTE of that person's salary. A commitment to stay in the clinical space of some degree. But that doesn't mean necessarily as a physician. It can be nurses as well. And that's really about it. It's much broader.
So I'm wondering, you've showed like quite a range of things that you've been involved with in terms of the implementation of these plans. I'm wondering if you could share some of the greatest lessons learned along your journey through disaster preparedness.
Absolutely. I'm going to use this as a framework for talking about what some of those lessons learned were. And that is the slide that shows our key project examples. So the construct of a national data portal was the creation really of a data repository that has informed our quality improvement collaboratives, but is also serving as a data portal for us to ingest data on research projects. Some of our lessons learned was that the challenges of not having IT support as an institution and part of the carve out of those awards really delayed some of that work. Another learning from the work with that data portal is that there are federal entities that are eager to look at the granularity of data through the network, through our networks, and are willing to serve as partners with their own resources coming to the table. One of those examples is we're working with an arm of the CDC to incorporate capacity and capability data and some of the predictive modeling. So those opportunities, unless you're reaching out to those federal entities and having those granular asks, you wouldn't know they were there. We just have to be bold in our asks. Resource Central, the opportunities in some of our learnings, rich positive learnings, is that using artificial intelligence and advanced large language models really help people to get to the right solutions quickly when they are looking for resources. On some of our community engagement work, so much of changing the outcome really meant developing grassroots to more sophisticated frameworks, approaches to working with schools, to working with churches, and to partnering there. We've also learned a lot about where some of the gaps within the gaps. You know, we talk about vulnerable populations here, and everything that I've talked about is where are the pediatric gaps in all of this work. But there are subgroups of pediatrics that present even more vulnerable populations. So a lot of our work has required us to grow this new special interest group that we have in children and youth with special healthcare needs. And whether that is highly burdensome chronic illness or multiple systems that are involved with that patient's diagnoses. Being pediatric ready looks very different in children and youth with special healthcare needs and all the sustainable, durable devices or ventilators or other items that are going to be necessary to care for those kids in disasters. So we're identifying subgroups within subgroups within subgroups as we grow all of these efforts. The amount of learning that we have had from all of our subject matter experts is creating all of these new special interest areas where we're finding subject matter experts and bringing them together. We've really grown quite a bit of strength in being a collaborator and creating collaborative subgroups.
All right, I'm just checking to see, does anyone else have a question or comment? And I'm not seeing anything else in the chat. I will just share a final slide then. So these are two QR codes. So the one on the left will take you to a registration page so you can see all of the upcoming science cafes. And then the QR code on the right is if you're not already a member of the CTSC, we encourage you to sign up and stay up to date with our upcoming events. And if there's nothing else, then we will sign off a few minutes early. And thank you so much, Dr. Macias. That was a great presentation.
Thank you. Thank you for the opportunity.
All right. Have a good day, everyone.
Thank you.